Thanks for the invitation, Vlad. So this is really more a talk on like the future research directions than the current clinical status of DBS. But I'm sure you will know a lot of the things that I mentioned, but I think they can serve as a good foundation to start discussing how we want to advance our research to the next level somehow. So. We all know this. DBS is super effective in Parkinson's disease for patients with motor complications, but it's also a very unique research platform and allows to record brain activity, allows to modulate brain networks, allows to combine clinical assessments and clinical variables with behavioral assessments and video recordings and brain signal recordings and MRI, MEG, all these different aspects. And I'm not going to talk too much about this, but we have these standard targets for DBS, the thalamus or VIM for tremor, GPI for dystonia and PD, and subthalamic nucleus for PD. And I think one of the innovations or advancements recently was that there's still some traction in how we perceive or what we believe what DBS does really. And this is summarized in a book chapter that I wrote for Andy's Connectomic DBS book, and we're currently working on a review article that tries to capture this. And basically, we have to be aware that when we are talking about DBS and the target area, like the subthalamic nucleus, we are affecting many different aspects of the network. And we are modulating, for example, the corticosubthalamic hyperdirect pathway axons. We are also modulating the pallidal input to the STN. We're also modulating the subthalamo-pallidal output. And something that I like to mention now is that we are gathering more evidence. So not our research group, actually, a lot of it is coming from Toronto, but the evidence of what it actually happens there. And I like to highlight this because I think the more we understand how DBS works, the more flexibly we can use it for other indications and try to translate findings from movement disorders, for example, also for neuropsychiatric disease. And for that, there are different things going on, and it's getting more and more complicated, of course, but at least what can be said is that the ultimate or imminent response of the neural activity to DBS pulses strongly depends on the afferent neurotransmitters. So in the subthalamic nucleus, it's quite complicated because we have a mixture of GABAergic input and glutamatergic input. So GABAergic is primarily from the pallidum, glutamatergic primarily from cortex, but also from other subcortical structures. And when a current or a single pulse is applied in the STN, you can see an immediate increase of firing rate and an excitatory response of the subthalamic neurons. That is followed by a trough indicating a bimodal response that is related to the mixture of afferents. So you have an activation through glutamatergic axons, but at the same time you also have a direct inhibition. In the VIM, the mixture of afferents is a little bit different. You have almost 90% glutamatergic neurons from the dentatorubro-thalamic tract and only maximum 10% GABAergic inputs through the reticular nucleus. And that leads to a change in the immediate response to stimulation pulses in this target area, where you can see that it's basically a monophasic increase of firing and excitation. Now, this seems quite complicated, and of course, yeah.
Was it the simulation, or what kind of?
This is intraoperative evidence in human patients. They recorded. They performed combined recordings with 2 microelectrodes that are super close together. It's a custom-made setup in Toronto that has been there for 20 years. So Will Hutchinson has established that, and now no one is asking anymore any questions. But it's a very versatile setup they have there, because they don't use the Ben gun, they don't use alpha omega systems, but they use these 2 trajectories that are much closer to each other than we are used to. So it's 600 micrometers instead of 2 millimeters. And they stimulate on one microelectrode and record on the other. And it's in direct proximity to each other. And that is how.
Do you think so? This is a simulation really comparable to like the one with standard microelectrode, or how is? Can there be any difference there?
Yeah, so that's possible. Of course, it is not the standard microelectrode, but I don't see why this should be too different, to be honest. Ultimately, the applied current overall is lower, I guess, because the contacts are smaller. But in the end, the response and also the results are quite integrable with previous research, also from animals. And what they observe is that initially you have this bimodal response, and you have like a target-dependent effect in the first seconds and sometimes even minutes. But after a while of stimulation, in all the targets, there is a synaptic depression. So there's still ongoing debate whether this synaptic depression is related to synaptic fatigue or drainage of neurotransmitter vesicles, or whether it's actually an effect of a disbalance between glutamatergic and GABAergic resilience. Because what was found in slice studies was that if you stimulate a glutamatergic neuron at 130 hertz, it stops firing almost immediately. So it's overwhelmed with the stimuli. While GABAergic neurons actually are more resilient and can sustain firing longer. And this would lead to a net inhibitory effect of high frequency stimulation, which is kind of also, I mean, there's not enough evidence for this in humans right now, but it's at least imaginable, because if you look at firing rates, natural firing rates of GABAergic versus glutamatergic neurons, there are these super fast spiking interneurons that are GABAergic, and overall it seems that even spontaneous firing of GABAergic neurons is usually at higher frequencies when compared to glutamatergic neurons. So this is kind of the micro level or the local firing effects of DBS. And I like to say this and show this because there's a very slow transition and still the ongoing debate about the hyperdirect pathway and its effect for stimulation. And from this perspective, and also integrating the idea of effective pallidal stimulation, there's very little evidence left for a relevant effect of antidromic hyperdirect pathway stimulation for the clinical side. it may still have cognitive effects or other side effects, especially through disruption of the neural communication. So basically, through this mechanism, this also means that whatever is meant to be communicated through the afferent synapses to the target nucleus is disrupted, right? So if the corticosubthalamic tract probably has a role in inhibition and the cognitive control, and that is for sure affected by the stimulation, but that doesn't necessarily mean that the clinical improvement or symptom alleviation in Parkinson's disease is associated with the stimulation or explainable by antidromic activation of cortex. And there's a very nice monkey study comparing the effects of GPI and STN stimulation and recording cortical neurons that really makes it very unlikely that antidromic activation of cortex is a relevant effect. And I like to advocate for the local suppression through synaptic depression as a relevant mechanism of DBS. Now, independent of that, we can also record beta activity, and I shouldn't say independent of that because this is also an ongoing debate, and we've had this discussion before on the computational modeling in our brain paper from 2018, where it is kind of questioned whether the beta band hyperactivity is related to increased firing or whether this is a network phenomenon that is unrelated. So the interconnection or interplay of local spiking and oscillatory synchronization, I think, is still not fully understood. But regardless of that, the effect of DBS on the local activity kind of resembles the microelectrode recording findings, and this we all know since a long time that beta band activity is suppressed with DBS, and we could show this now for the first time with the new Percept system, with stepwise increases in stimulation amplitude, and you can see that there's the beta band activity follows the stepwise increase in stimulation amplitude quite nicely, actually. There will be a little bit more on this topic later on after the official MDS part of my presentation, so we can discuss this later, I think. But what is clear to me is that this opportunity to record like really good signal-to-noise ratio LFP with an implantable device is now possible, and you can see like the combination of video and beta time frequency plots, and also having the location there. You can see the averaged beta power as a color of the SDN and the increase in stimulation amplitude over time as the volume of tissue activated. It will pop up soon. And you can see both this, I think it's also a very nice part where you can see the post-movement beta resynchronization really strongly, and indicated here as the blue STN already, like a small stimulation amplitude really decreases beta, but also improves the clinical symptoms. I think overall this is gaining a lot of complexity now with having to look at the video, at the raw signals, at the beta band, at the localization. But I think it's a really relevant technical innovation that this is now feasible and easily doable. So ultimately, I think that we can try to integrate the effect of DBS on the local spiking level and basically see the desynchronization or synaptic depression that is observable in the subthalamic nucleus as a part of kind of a fractal nature of DBS effect, which is desynchronization in general. So when we're stimulating in the SDN, we are desynchronizing the local neural population, but this also leads to a desynchronization of local neural populations in the other nuclei, and ultimately to a desynchronization of the network itself. And this can be observed in the, when recording spikes in or even in slices, but can also be observed at the level of LFP and neural oscillations locally, or at the level of coherence with MAC-LFP, like you have shown, or at the level of whole brain imaging and connectomics. So the current main advances are, to repeat this, the understanding of the DBS effects, and I would like to encourage you to have a look at this paper if you're interested in the computational framework that is underlying the idea of afferent neurotransmitter dependent effects of stimulation. So this is what my slide also depended on, and this is the latest publication from Luca on this topic. And we are following up with a review article soon. And but there are also other mechanisms that may in the future be able to improve DBS beyond the simple high frequency stimulation that we tried to explain in the first part. So there's this, I think, at least interesting approach where you can use phase-specific stimulation to try and predict oscillatory modulation. And this may, in the future, make a more specific modulation possible that is not similar to what I explained regarding synaptic depression, but rather a more circuit-targeted intervention. I'm hesitant to believe that all of the findings that are described in this paper are really reproducible. There are some oddities in the results sections there, but I think at least the idea already is super nice and an advance in how DBS may modulate the circuit. Now we have.
So what is the idea? Is it just phase cancellation, or is it something more than that? What is the idea in that paper?
Yeah, it's not primarily phase cancellation through trying to find the same phase with the same frequency stimulation, but it's a model that tries to optimize the current to decrease the phase-specific effects. But I'm not sure exactly how they implemented that. It's based on phase cancellation, but it's not simply for beta stimulating in a beta. It's more complex. You can have a look at that. I read the paper just before I gave the talk at Movement Disorders. I already forgot again. Sorry about that. But what they show here is that it could be possible to suppress or amplify the stimulation effects. And I think the stimulation frequency was above 30 Hertz. So it wasn't simply stimulating in the same frequency band. Now, we can also use like whole brain connectivity, try and understand behavioral changes. And this is our last paper on this topic, where Roxanne has looked at the effect of DBS on stopping of ongoing movements. So this was a task that we designed, again, using a tablet where patients were steering a cursor on the screen. They were asked to move around this donut, basically. And at random intervals in between with a jitter of 2 seconds, there were stop signals and the patients were asked to stop. And then after that, there came a go signal again with the jitter and the patients moved again. And we have quantified the effect of DBS on the ability to, and the speed of stopping, and found that the connectivity to pre-SMA and inferior frontal gyrus could predict the loss of capacity to stop quickly. So DBS does also decrease the ability to stop in a very fast manner. And this is contextualized in the inhibition triangle concept of Adam Aaron and Russ Podrak, and basically kind of corroborates this idea of a right lateralized stopping network that interestingly is mostly associated with the stopping time, even though the stimulation was applied bilaterally. But independent of like behavioral effects, of course, you also know Andy's latest works, and I mentioned this here, that fiber tracts and whole brain connectomic can also predict stimulation outcome. And I think this is quite a nice picture of their OCD work, where they show that a lot of the targets for OCD are in a very similar trajectory of a certain fiber tract that they identified. And given that there's a lot of discussion and even some maybe conflicts on the naming of this tract, I heard recently from Andy that he is now not going to call this any anatomical structure anymore, but rather call it the DBS, OCD DBS response tract. It was called before the medial forebrain bundle, especially by Volker Köhnen, and then they argued that it's probably more likely to be a part of the anterior limb of the internal capsule. But in any case, what they show and what is interesting for the ideas of how we advance DBS is that regardless of the target, whether it's STN or the ALIC or BNST target, the optimal response is predictable by a certain fiber tract that can be affected or not affected, or more or less affected by the DBS contact. So I think you can understand or try to conceptualize this in two ways. One is trying to understand the anatomy that is related to the disease, for example, like trying to understand what this means for OCD. But for this question, I think the technique is not really designed, and sometimes there can be misunderstandings because basic neuroscience researchers expect this to be accurate anatomical depictions, and then they argue against it because it doesn't look exactly like what is known. And the way it is more often and more understandably conceptualized is that the fibers kind of represent a spatial model. And this spatial model helps to predict the stimulation outcome. And it is quite good at that, actually, compared to other kinds of prediction models. And it can integrate different targets. So it's a more complex version of an anatomical target, but it remains a target that is not really understood. Yeah. Then a recent thing that we have all looked at and I found worth mentioning is that not only power and synchronization across nuclei is interesting for future DBS research, but also temporal dynamics. And I'm sure you have seen this recent paper by Helen Bronte-Stewart, which kind of did a global shot at what can be done with beta activity in the SDN in Parkinson's disease patients. So They looked at stimulation-related suppression of DBS. They looked at the locations, and they looked at the volume of tissue that is activated by DBS and how this affects the oscillatory dynamics, and found that the more you modulate the sensory motor part of the STN, the stronger is a change in burst duration towards shorter bursts. And this nicely integrates with Peter's and Gert's work on beta bursts. And I think it's worth mentioning and nice because it also integrates the neuroimaging part with temporal dynamics advances. Side, we have just performed this larger cohort study that is under review now, or at least submitted, where we looked at the stepwise responses. I've already shown you a similar image, but this is the first real cohort study where this is assessed within patients with the Medtronic Percept and also related to movement. And I think this is really encouraging for the basic adaptive DBS trials, because we could show that there's this double correlation of stimulation with beta suppression and also change in movement velocity. So beta during stimulation at different amplitudes is nicely correlated with changes in movement velocity or with clinical symptom alleviation in 13 patients. Now, I think where we should head to with this kind of implantable technology is something like this. So I think Nantia Sultana, you may have read about her research, is really good at making the most out of what is possible with implantables. I think the slide is somehow, yeah. Somehow the size of this image changed. So this is Nature paper 2021, where they used the RNS neuropace device and an implantable sensing-enabled device for epilepsy that is FDA but not CE marked. And they looked at oscillatory local field potential activity from the hippocampus in human patients with epilepsy, and had this immersive environment where they look at the combination of self-navigation and interaction of participant and experimenter, and found that you can identify spatial boundaries similar to boundary cells in the context of place cells, and based on oscillatory signatures. So this is not DBS, but this is brain stimulation with sensing-enabled implantables, and this really shows what's possible. Of course, we have to acknowledge that these epilepsy patients, I'm not sure if this is a model or if this is a true patient, but in any case, those patients are usually much less affected at the moment of recordings. Of course, epilepsy, intractable epilepsy, is a very, very severe disease, and it's really debilitating. But in the moment where the patients do not have seizures, they are usually highly functioning. And that makes, of course, such a setup easier than in the context of movement disorders and Parkinson's disease research. But nevertheless, I think this can serve as a very nice motivation and inspiration for us to try and take DBS in the context of movement disorders with sensing-enabled implantables to the next level. I think another step forward is the use of or combination of machine learning with adaptive DBS, and here I'd like to mention the OPRI 2020 paper from Ayşe Gunduz's lab, where they used also the PC plus S device and trained machine learning models to predict the presence of movement, and used that for alleviating essential tremor or action tremor in patients with essential tremor. And this is only 3 patients, but what is really cool in this study is that they managed, with the help of Medtronic, to have this fully embedded. So the patients could actually run around and have machine learning based adaptive DBS without any requirement for external intervention. And this is really the first time I've seen this, that even on the implant, I think it's a LDA classifier that was implemented, and it actually worked quite well for the detection of voluntary movement. And what they show is that, first of all, that allowed to do this over months. And they show basically that the performance is in the range of 80 to 95%. That is the classification performance. And the clinical improvement is very similar. Maybe I did not show the plot here, but what you can see is that even though there's no significant difference in adaptive versus open loop continuous DBS, the energy applied is roughly around 50%. And I think this matches quite nicely with the study from Hulding and the externalized machine learning based adaptive DBS in essential tremor patients using only thalamic data. Now, this is also kind of what we're working on a lot now, trying to improve our machine learning for example, movement velocity or grip force decoding. So this is just one example where you can see the features, so oscillatory frequency bands of ECOG activity in the back, and the white line is our decoding of grip force. The red and blue areas are contralateral versus ipsilateral movements. And there are, of course, many different machine learning approaches, and we are still kind of getting mixed results of what is working best depending on the question and the application. And I think learning more about this will really help us to define the optimal ways to combine machine learning and therapeutics. And what we envision in the end is kind of a fully integrated approach from understanding the network architecture, target fiber bundles as an unleashed research, but maybe also changes in the integrity of the network before the operation to really identify optimal targets, and then combine that afterwards with electrocorticography and subthalamic LFP recordings to really kind of modulate the optimal amount and really adapt stimulation to what is required for the patient at the individual time point. And from my perspective, it doesn't have to be a pathophysiology biomarker. I think in the future, what would be much more helpful for the patient is to try and define optimal stimulation settings for certain behaviors or activities of daily living, and then trying to use machine learning to decode the necessity to change to these parameters. So to summarize what I mentioned, I think we have now an advanced understanding of stimulation mechanisms, and this will allow the therapeutic refinements, potentially through novel stimulation parameters. Then we have these sensing-enabled stimulation implants that will help us to really objectify and quantify the clinical utility and success of adaptive deep brain stimulation, especially in the classic approach of beta-based ADBS, where ADAPT-PD trial has now started and first centers are recruiting. Then connectomics allow the definition of brain circuit targets and also in the future network programming. So even after implantation, you can look at the fingerprints of the stimulation target, the connectomic fingerprints, and try to adjust and optimize this connectomic fingerprint towards the fingerprint of the optimal response. And then I'm really a believer that machine learning in the context of adaptive DBS will make the closed loop approach worthwhile. I'm not sure how far we can get without adjusting stimulation to really what the patient needs and only using a pathophysiological biomarker. So ultimately, to taken together, I think that at some point we could outperform traditional drug treatment with deep brain stimulation because we have the temporal and spatial precision that is impossible to reach with drug treatment. So stimulating the right circuit at the right time and making that as individual and precise as possible. So that's basically the movement disorders talk. And now I just added here the slides on our Percept study, so we can discuss a little bit about this because I think you were interested in how Percept is going forward. So we've already seen this. This is the biggest study that we have finished now. We're kind of reproducing this in longer term recordings. This is really short term after DBS implantation, where we stimulated at increasing amplitudes and try to quantify the effects of DBS. It's not surprising, so there were no big surprises. It worked quite well, and we have shown what was expected, that there's a stepwise modulation of beta, and that is followed by the clinical response. And it's also possible to look at that during movement, and we are working on that, but I just want to remind you that the way this study was designed or analyzed at this point was beta band activity at rest and compared with movement velocity and behavior assessed directly after the resting activity that was used for the correlations. So we we did kind of a block design where we had resting, movement, resting, movement, resting, movement, and for the correlation and investigation of DBS effects, we only used the resting activity. And yeah, so then we also assessed the frequency specificity and found that especially in the high beta, but also in the low beta, there's a diversion of power and clinical effect. So in this case, to make, because not every patient had exactly the same stimulation parameters, we grouped the stimulation amplitudes into having being turned off, having less than 50% effect, having more than 50% effect, and having the best possible clinical effect. And 50% is relative to best clinical effect. And you can see that even at the more than 50%, there's already a jump, but it's not a fully linear change of activity. It's rather a switch from beta still being present to beta being quite low from one moment to the next. And we found the best correlation with behavior in the low beta band, and this was the mixed effects model here, looking at the correlation of stimulation amplitudes and velocity assessments or clinical assessments within patients. And this is the model output, just accumulating all the different patients. And this is trying to quantify the nonlinearity of low beta activity in response to stimulation. So you can see that it's not a linear decrease, but it's kind of a more logarithmic or exponential decrease here. Yeah, this is just a figure showing the locations. That's not too relevant here.
Julian?
Any questions to this?
Yes.
We'll discuss general Percept stuff. Maybe after this, only one slide left, and that is just advertising our last publication, where I have worked with Tim Dennison to try and understand the ECG contamination, something that I have not mentioned so far, but many people have heard of. And we have kind of asked many different centers for data on ECG contamination, and found that basically there is ECG contamination in roughly 50% of the channels, if on average, but that is in Percept, and that is dependent on where exactly the stimulator is implanted, and particularly the stimulation, if the DBS device is implanted close to the cardiac dipole, there's a higher risk of ECG contamination. So, but the degree of contamination overall really varies. So you can see that we have some beautiful recordings with very strong beta activity. This is always a 20-second snippet, a 5-second snippet below. And there's, in this recording, this is a subclavicular implant, subthalamic nucleus, where there's no ECG to be seen in the LFP. But then we also have a lot of recordings that have kind of minor ECG contamination. And these are particularly hard to treat in a way because they don't severely affect the spectrum, but they do. They're not easy to clean and not easy to identify or objectify at least. And then we have these super obvious, very high amplitude ECG artifacts, and they severely affect the power spectrum and make it impossible to use the data without any further cleaning. Now, ultimately, we quantified how many patients are affected by ECG contamination if they wanted to participate in the ADAPT-PD trial or any other adaptive DBS trial. And we found that with left implants, something that was common procedure here in Berlin, implanting the DBS device or IPG into the left chest, we would actually only have 50%, less than 50% of the patients ready or fit for bilateral ADBS. So, and we found that very relevant because if you promise a patient a new device and tell them that they might be able to benefit from new stimulation techniques, it's important to tell them also that there is a 50% chance that they cannot participate because of stimulation or ECG artifacts or technical artifacts. Now, at least 80% had one hemisphere that could have worked, but the number of channels that are severely affected with ECG dramatically decreases if the implant is in the right chest. And the moment we noticed that, we switched the sites. So basically, we've seen a few first cases and discussed this with Tim. And I talked to our neurosurgeon. He asked me to discuss this with a cardiac interventionalists because there was still a historical worry that it's better to implant the cardiac pacemaker on the right side in case one becomes necessary for the patient at a later time point. But the cardio interventionalists promised me that they don't really care whether they implant on the right or left chest. So that made it possible to really switch from one moment to the next to always implant Percept devices in the right chest. And this has really, really influenced our signal fidelity. Now, one additional aspect that is mentioned in the paper and assessed is the fact that if you have a cranial implant, you are very far away from cardiac dipoles, and you don't see any ECG. And we actually included also empirical data from cardiac implants from the RNS Neuropase device from Mark Richardson's group. I think those were like 20 or almost 30 patients, and they have not seen a single ECG artifact in these 30 patients or channels. And here's, you can see even a thalamic. So this is a subcortical implant recorded with RNS Neuropase. And also there is no ECG artifact. So in the future, similar to what was shown in Nantia Zutana's paper, such devices definitely have a better signal fidelity because they are less affected by ECG and also less affected by movement artifacts of the trunk and neck. Yeah, so I think that's it. I, of course, want to thank our team, all know Andrea, also Andy, collaborators, and then my own group who have helped a lot.